independent strategic actions including reorienting health-related national policies towards PHC, increasing PHC
like
financing,
the
reorganizing PHC service delivery, enabling community participation, strengthening PHC workforce teams, ensuring access to affordable, quality-assured essential medical products, leveraging digital technology, strengthening health information systems, and institutionalizing learning systems. The strategy also proposes a monitoring system to assess, track, and drive progress. Expressing WHO's commitment, Dr. Poonam Khetrupal Singh, the Regional Director, WHO Southeast Asia Region said, "We will fully support member states of the WHO Southeast Asia region to realize this historic opportunity of strengthening the PHC orientation of their health systems. It is time to seize the moment and deliver on the vision of health for all."
This is Nina and her family. It is a very precious moment for them. They have had a long journey to get here, all together, healthy and happy. When she was pregnant, Nina's mother had a difficult and complicated pregnancy, but Nina's father was able to rush her to the clinic just in time when she had dangerously high blood pressure. Nina's older brother was diagnosed as HIV positive. Her grandfather had a stroke last year, and Nina's grandmother is finally being treated for tuberculosis after months of painful coughing. Like many other families, Nina's family also has had to deal with a lot of illness. They are very fortunate though. There is a health clinic a short distance from where they live, and they can access skilled healthcare providers and services that they can afford. In the country where Nina lives, people voted for country leaders who are committed to achieving universal health coverage by 2030. Through a progressive system, wealthier people contribute more money, and the government is able to provide an essential, affordable package of health services to all people, leaving no one behind, regardless of income, health condition, background, or where they live. So what looks like a simple meal is really a very special occasion for Nina's family. They had a long road to recovery, but never had to choose between getting healthy and putting healthy food on the table. And this sets them apart from many people around the world who can't afford or don't have access to essential quality health services. Every family, everyone deserves universal health coverage. Let's work together towards good health and well-being for all.
Around the world, people are living longer, but often with multiple diseases and conditions that require care over many years. And unfortunately, too many people are not informed or consulted in the care they receive. In some countries, only 1 in 3 people have the risks of their treatment explained to them. 1 in 5 people have at least one unnecessary test, and up to 40% of health spending is wasted due to inefficiency. Healthcare should not be like this. Remember, people live with their condition 24/7, not only when they seek care. That's why people-centered care is so important. People-centered care means ensuring that health services are tailored to people's needs and are provided in partnership with them rather than simply given to them. It means care where people, families, and communities are respected, informed, engaged, supported, and treated with dignity and compassion. People-centered care can have lasting benefits. It improves the trust, experience, and outcomes people have from care, the confidence and job satisfaction of health professionals, and the quality and efficiency of health systems. People-centered care can increase access to health services and reduce unnecessary use of services, Ultimately, it means people get the right care at the right time and in the right place. But too often, this type of care is not standard practice. Implementing people-centered care requires fundamental changes in our approach to healthcare. It means rethinking how health services are organized, managed, and delivered. It means shifting away from asking, "What is the matter with you?" to "What matters to you?" Around the World Health Organization is working with countries to design health systems that put people and their needs at the center of care. Because that's the healthcare that everyone deserves.
Hi guys, I'm Alisson Becker, goalkeeper for Brazil and Liverpool, and Goodwill Ambassador for the World Health Organization. Saving goals is my job, but there is another goal I aim for every day: to play my part in helping save lives. I am proud to be a member of Team WHO and its global partners who work day and night to protect and promote the health of people all around the world. On Universal Health Coverage Day, let's all be active and play our part to make health for all our #1 goal.
History is made by our achievements. We have come a long way to make the impossible possible. When we come together, lives are changed. The next historic achievement is right in front of us. Health. What if everyone had access to the health services they need and were not pushed into poverty, paying for it? Together, we can make health for all happen in our lifetime. It's time to make history again.
Here's Drogba, and it's a wonderful goal by Drogba.
So I actually broke through to professional football later than some people would think. I worked hard on and off the pitch during those years to make a success of my career and to set a foundation for myself and my family. I found myself in the unusual place where if I had a problem on the field, help arrived quickly. And we've seen how vital that support can be lately. But off the field, we know this is not always the case. Ill-equipped clinics and supported health workers and not enough medicines and vaccines put people's well-being at risk around the world. Good health needs a team effort, so we need governments to commit to policies that support universal health coverage and give everyone access to what it takes to be healthy physically and mentally. When we team up for health for all, we all win. Let's make health for all our goal.
The imperative to strengthen primary healthcare, or PHC for short, has never been more compelling and urgent. PHC is critical to ensuring the health and prosperity of the people in WHO's Southeast Asia region. It brings the health system close to where individuals live and work and enables a multi-sectoral response. Home to more than 2 billion people, the WHO Southeast Asia region faces multiple health-related challenges. These include the increasing burden of non-communicable diseases, persistence of communicable diseases, increasing cost of healthcare, public health emergencies, and health implications of demographic shifts, rapid urbanization, and climate change. The region also has high levels of poverty, social and health inequities, low public spending on health, and high out-of-pocket expenditure. These challenges have been further aggravated by the ongoing COVID-19 pandemic.
So I just want to make sure as if for the inaugural session.
As early as 1937, PHC was identified as the most suitable approach to meet the health needs of the poor and the hard to reach. The pandemic has brought into sharp focus the importance of PHC. Countries with stronger PHC-oriented health systems were able to respond better to the pandemic while maintaining essential health services. With the aim to build back better, in September 2021, the Ministers of Health committed to seize a once-in-a-century opportunity to prioritize PHC as the means to simultaneously advance health security, achieve universal health coverage, and attain the health-related SDGs. To support the countries in implementing this momentous decision, WHO launched the Southeast Asia Regional Strategy for Primary Healthcare 2022 to 2030. At the heart of the regional PHC strategy are its 7 core values that will serve as a constant guidepost. The strategy encompasses 12 interdependent strategic actions, including reorienting health-related national policies towards PHC, increasing PHC financing, reorganizing PHC service delivery, enabling community participation, strengthening PHC workforce teams, ensuring access to affordable, quality-assured essential medical products, leveraging digital technology, strengthening health information systems, and institutionalizing learning systems. The strategy also proposes a monitoring system to assess, track, and drive progress. Expressing WHO's commitment, Dr. Poonam Khetrupal Singh, the Regional Director, WHO Southeast Asia Region said, "We will fully support member states of the WHO Southeast Asia region to realize this historic opportunity of strengthening the PHC orientation of their health systems. It is time to seize the moment and deliver on the vision of health for all."
I think or representative co-host.
This is Nina and her family. It is a very precious moment for them. They have had a long journey to get here, all together, healthy and happy. When she was pregnant, Nina's mother had a difficult and complicated pregnancy, but Nina's father was able to rush her to the clinic just in time when she had dangerously high blood pressure. Nina's older brother was diagnosed as HIV positive. Her grandfather had a stroke last year, and Nina's grandmother is finally being treated for tuberculosis after months of painful coughing. Like many other families, Nina's family also has had to deal with a lot of illness. They are very fortunate, though. There is a health clinic a short distance from where they live, and they can access skilled healthcare providers and services that they can afford. In the country where Nina lives, people voted for country leaders who are committed to achieving universal health coverage by 2030. Through a progressive system, wealthier people contribute more money, and the government is able to provide an essential, affordable package of health services to all people, leaving no one behind, regardless of income, health condition, background, or where they live. So what looks like a simple meal is really a very special occasion for Nina's family. They had a long road to recovery, but never had to choose between getting healthy and putting healthy food on the table. And this sets them apart from many people around the world who can't afford or don't have access to essential quality health services. Every family, everyone deserves universal health coverage. Let's work together towards good health and well-being for all.
Around the world, people are living longer, but often with multiple diseases and conditions that require care over many years. And unfortunately, too many people are not informed or consulted in the care they receive. In some countries, only 1 in 3 people have the risks of their treatment explained to them. 1 in 5 people have at least one unnecessary test. And up to 40% of health spending is wasted due to inefficiency. Healthcare should not be like this. Remember, people live with their condition 24/7, not only when they seek care. That's why people-centered care is so important. People-centered care means ensuring that health services are tailored to people's needs and are provided in partnership with them rather than simply given to them. It means care where people, families, and communities are respected, informed, engaged, supported, and treated with dignity and compassion. People-centered care can have lasting benefits. It improves the trust, experience, and outcomes people have from care, the confidence and job satisfaction of health professionals, and the quality and efficiency of health systems. People-centered care can increase access to health services and reduce unnecessary use of services. Ultimately, it means people get the right care at the right time and in the right place. But too often, this type of care is not standard practice. Implementing people-centered care requires fundamental changes in our approach to healthcare. It means rethinking how health services are organized, managed, and delivered. It means shifting away from asking, "What is the matter with you?" to "What matters to you?" Around the world, the World Health Organization is working with countries to design health systems that put people and their needs at the center of care. Because that's the healthcare that everyone deserves.
Hi guys, I'm Alisson Becker, goalkeeper for Brazil and Liverpool, and Goodwill Ambassador for the World Health Organization. Saving goals is my job, but there is another goal I aim for every day: to play my part in helping save lives. I am proud to be a member of Team WHO and its global partners who work day and night to protect and promote the health of people all around the world. On Universal Health Coverage Day, let's all be active and play our part to make health for all our #1 goal.
History is made by our achievements. We have come a long way to make the impossible possible. When we come together, lives are changed. The next historic achievement is right in front of us.
Good morning, everyone. May I request everyone to be seated? We'll get started shortly. Should we announce? Good morning, everyone. A very welcome to all of you to the high-level summit on UHC weekend. For the inaugural session, may I request Dr. Poonam Khetrapal Singh, Regional Director to WHO Southeast Asia region, to deliver her opening remarks. Thank you.
His Excellency, Dr. Lote Shering. It's a virtual meeting. It's a hybrid meeting. So a lot of them have joined online, including the Honorable Prime Minister of Bhutan. His Excellency, Mr. Anutin Charan Virakul, Deputy Prime Minister and Minister of Public Health, Thailand. His Excellency, Mr. Rui Augusto Gomes, Minister of Finance, Timor-Leste. His Excellency, Mr. Ahmed Naseem, Minister of Health, Maldives. Dr. Vinod Paul, Member Niti Aayog. Mr. Gagan Thapa, Parliamentarian from Nepal, high-level dignitaries, technical experts, development partners, members of civil society, and colleagues from WHO. Good morning and welcome to this International Universal Health Coverage Day celebration. It is a pleasure for us to host you today. Today is a day to celebrate progress, to take stock of where we are, of our journey, and to revisit and reflect on the many signposts on our way, from Bandung, Alma Ata, then Astana, to our flagship priorities, the 2019 UN Political Declaration and next year's UNGA high-level meeting. It is a day to empower and engage people and communities, and to emphasize that to achieve health for all, we must be all for health, the theme of this year's regional commemoration. Because we know that no one person or policymaker can achieve UHC. Rather, it requires a dedicated whole of government, whole of society action that is equity focused and which establishes quality, accessible, affordable, and comprehensive primary health care, the strongest foundation to achieve UHC, health security, and health for all. You are aware, this is the focus of the global PHC operation network, and as well as the Southeast Asia Regional Strategy for PHC, launched last year at the UHC Day. The PHC approach has three major components. First, better integrating health services with an emphasis on PHC and essential public health functions. Second, strengthening multi-sectoral policy and action. And third, empowering people and communities. It is also aligned with the region's resolution on enhancing social participation in support of PHC and UHC, which was adopted this year at the regional committee meeting which we held in Bhutan. The resolution calls on countries, partners, and WHO to strengthen social participation, community engagement, and empowerment for UHC, with a specific focus on establishing collaborative platforms for shared learning and strengthened national capacities. Finally, it was a key point of discussion at the region's recently concluded workshop on strengthening PHC, at which it was a pleasure for us to launch a new regional framework for PHC-oriented health systems. I thank all those who participated in the workshop and launch, which was highly successful. Even before the COVID-19 pandemic, in 2017, around 299 million people in the region faced catastrophic health spending. An estimated 117 million people in the region were pushed or further pushed below the purchasing power parity poverty line of $1.90 a day. Though the region increased its UHC service coverage index from 47 in 2010 to 61 in 2019, gaps and challenges have continued to negatively impact the health and well-being, lives and livelihoods of the vulnerable. Need it be said, COVID-19 pandemic has exacerbated such gaps and challenges and pushed tens of millions of people in the region to extreme poverty. It has intensified fiscal pressures at exactly the moment in which health and social support must be maintained and even increased for a healthier, more rapid, more equitable, and more resilient recovery, and to accelerate progress on each of the health-related sustainable development goals, as well as social and economic progress more generally. Today, to accelerate health for all through All for Health, I highlight several priorities. First, multi-sectoral action must be urgently promoted, and our health in all policies approach should be rigorously adopted. Good health and well-being begins not in hospitals and healthcare facilities, but in homes, in schools, in workplaces, and in neighborhoods. In all settings, decision makers must be sensitized and empowered to protect, to promote, and to support health and well-being, and to mitigate its social and economic determinants. Second, social participation must be mainstreamed within the health system, governance, and decision-making, ensuring that stakeholders' views, experiences, and needs are listened to and considered in the decision-making process. For this, policymakers and providers must directly engage with the people, including through spaces and mechanisms that are participatory, and inclusive, that minimize power asymmetries and are oriented towards those who are at risk or those who are being left behind. Third, legal frameworks. Legal frameworks must be developed. They must be implemented and enforced to assist populations to enjoy the right to health through UHC. Evidence shows that well-designed legislation that protects and promotes population health increases social participation and with it, accountability. It can also help ensure that whatever the fiscal outlook, health is allocated adequate, sustained, and reliable public funds. Which brings me to the fourth point, financing. The COVID-19 pandemic has shown that when health is at risk, everything is at risk. Lives, livelihoods, trade, travel, individuals, families, and communities. But it has also shown us that when health systems achieve strong coverage and quality, they are better positioned to prevent and respond to acute public health events and therefore limit health, social, and economic impacts. This is why, amid the ongoing COVID-19 response and recovery, WHO is advocating for all countries of the region to not just sustain, but increase public health expenditure and PHC, especially on PHC. For this, among other evidence-based strategies, we are calling for increased taxation of unhealthy products, such as tobacco, alcohol, highly processed food, and sugar-sweetened beverages. I'm just coming from a meeting in Geneva of the heads of country offices, where Jeffrey Sachs was the guest speaker. And this is what he insisted on. And I showed him Thailand's example, which is being followed by several other countries of the region, how the tax on tobacco and alcohol can really go a long way in helping those who are vulnerable and increasing health budgets. My first message is that UHC is as much about the journey as it is about the destination. It is a goal that must be progressively realized, not just in systems and structures, metrics and percentages, but in how people from all walks of life think about and engage with health and well-being and the environments that support it. Let us agree, health for all, through all for health, is not merely a means to an end, but rather an end in itself. It is an outcome that must be cultivated daily, weekly, monthly, and yearly in all aspects of our work and as a core component of our onward quest to build resilient health systems that are PHC-oriented, people-centered, inclusive, and sustainable, leaving no one behind. Together we can, and together we must. Thank you.
Thank you, RD Madam. Now may I request Mr. Manoj Halani, Director, UHC Health Systems, to briefly introduce on series of events planned to commemorate International UHC Day.
His Excellency Dr. Lote Tshering, Honorable Prime Minister of Bhutan, Excellencies from Timor-Leste, Thailand, Maldives, India, and Nepal, respected RD Madam, distinguished dignitaries, partners, my dear colleagues and friends. Good morning to you all. UHC Day is a day when we advocate as well as recommit for UHC so that we achieve health for all and that no one is left behind. To build momentum for the UHC, we organized a series of events. These comprise of 3 activity groups: the UHC we want, the UHC we have, and the UHC We Can. I mean, one was aspirational, one was operational, and one was UHC We Can Today's Summit. Each activity group had its own set of objectives and deliverables, but all contributed to the overall general objective to promote engagement and ownership of the youth and future health leaders in the region for the operation of UHC. We organized a webinar on the UHC we have on December 8th. We shall hear about it from one of our partners and co-host of the webinar, IPSF, during the course of the program. To promote awareness, engagement, and ownership of youth in the region for the vision of UHC, we organized a region-wide art and creativity competition for youth under 25 years, 12 to 18, 19 to 25, and below 12. On the theme of UHC We Want, the art competition had 3 categories for different age groups. These were a drawing painting competition, a digital art and photography section, and a short video film making contest. We received good number of entries overall, and these were assessed by renowned artist, Ms. Arpana Kaur. The participants painted, photographed, and filmed the ideal health system that they wish to experience in their communities and countries. And taking this as a cue, it's our duty as the baton holders to translate their dreams and visions into a reality. And finally, we have compiled all these artworks we received from our UHC We Want initiative into a short video, and I hope you enjoy it. Thank you so much.
Now, may I request the audience to watch a video on UHC We Want. It is a compilation of art competition held to create awareness about UHC. Thank you. Thank you, everyone. We are honored to have with us, joining virtually live from Bhutan, His Excellency Dr. Lote Tshering, Prime Minister of Bhutan. May I now request him to deliver his keynote address on making whole of government approach for UHC a reality.
Excellencies, Dr. Pranam, distinguished speakers, and all the participants, greetings from Bhutan. And at the very outset, I have the honor of conveying His Majesty's warm greetings to all the participants today. And I thank Dr. Pranam and your Zero team for having me on this occasion, as well as the journey that we have made until now. We are all aware of your personal contribution as well as the contribution of Zero. And we heard you during the 75th RC at Paro a couple of months back. So thank you very much for that. In fact, I've been sharing with everyone and at all events that anything to do with health excites me a lot. So I would like to thank and be comfortable with my health fraternity friends. In fact, whether you call it universal health coverage or whether you call it healthcare system or basic health system, I think that touches every heart, every individual for that matter. And this year's theme is actually very, very relevant that we all need to relook and rethink on this UHC event. I think at all times, at any given point in time, I would say healthcare and healthcare system would be very pertinent and close to everyone's heart. But this time around, I think coming out of the pandemic, very unfortunate that we had the pandemic and we lost millions of lives to it, but very, very unfortunate and the wrong timing of the geopolitical situations that we are facing now. So I think of all times, this would be one very good time for all of us to come together, think and rethink on the needs of our global population. If you are not careful and if we are a little complacent at these times, I'm sure more damages would be done by the aftermaths of the pandemic and the geopolitical situation that we are facing now. I cannot imagine the millions of people whose routine healthcare system could not be covered up during the pandemic. Many routine health checkups and follow-ups could not be done, resulting in many lives that are going to be hampered. So with this, I personally feel that this is timely for all of us, and we are all excited to gather our thoughts on this. We know that during the pandemic, as we were gearing up our forces to save our lives, I was sharing my views with my health team in Bhutan that we should at no point compromise our routine healthcare system. And we went all out to make sure that our routine healthcare system was happening as planned. And we are very happy to report to the floor here that during the peak of the pandemic, we could also introduce HPV vaccine for the boys and also continue with all routine immunization program and also start a health flagship program to cater to the needs of people in the rural villages who could not come to our healthcare centers. And then we also went all out to make sure that routine pockets of public health issues like malaria and dengue fever outbreaks that we normally have. And I'm happy to report that we did not have those small outbreaks, pockets of outbreaks during the pandemic and coming out of the pandemic. But having said that, Bhutan is a small country. We are a small population. It will be very difficult for the global system to copy what we are doing now, as well as we have a leader like no other in His Majesty the King. During the pandemic, His Majesty had gone all around the country, went all out to save lives, and now we are all out to make sure that Bhutanese people do not suffer from the aftermaths of the pandemic. On universal healthcare, even before the global population started talking on universal healthcare or universal health coverage, we had it clearly written in our constitution that basic healthcare, both in forms of modern as well as traditional medicine, should be free and accessible for every Bhutanese. And with this, we also have a constitutional provision to provide free healthcare, free education for every Bhutanese. I think that is one strong component that we are already on to providing UHC for everyone. And going further, His Majesties the Kings have always insisted that good quality health and education and easily accessible for every Bhutanese would ensure social harmony in the country. And these are most effective social levelers in our country. So that is something that we have always insisted on, and we will continue to do so. And when we talk about UHC, I think few points that we all are aware of is accessibility, affordability by everyone, and also timely availability and quality of healthcare. Now, when we say affordability, I think we all have to play our parts. As Dr. Poonam rightly said, good health do not start or happens at good healthcare centers. It starts at home in all the relevant institutions. So on this front, when we talk about affordability, we always tend to think about curing or taking care of somebody who is sick. I think a lot of focus needs to be paid on preventive aspect, because if we have a good preventive system, that would take care of most of the components of UHC, I would say. And on that front, whenever we talk about UHC or health issues, we get carried away with major health ailments like cancers and NCDs, and we tend not to focus too much on mental health care, which I personally feel that should be an important chapter in every country's health chapter. On this note, during the pandemic, Her Majesty the Queen have realized that we have lots of vulnerable sections of our society who are not taken care of by formal health policies in the country, health do's and don'ts in the country. So during the pandemic and coming out of the pandemic, Her Majesty realized the need to take care of or to give a holistic care of people who could be or who are affected by mental health issues. So with this, we are very happy to share that Her Majesty the Queen have started a mental health institution called the Pema Center. This has the potential to grow into a formal state-of-the-art mental health institute in the country. And we are also very grateful to Dr. Poonam and her team that they decided to have the 75th RC in Paro in Bhutan, and also have the Paro Declaration focused on mental health. We're very happy to hear that, and we will give whatever it takes to make sure that it is implemented in the best way possible. We also would like to share that for Bhutan, as I said, since we have His Majesty the King as our leader, and we are a small country, we will not be able to share the experience to be copied by every other countries. But for us, we're very happy that we will have very soon a new health policy that is being drafted, be approved by the government. That should take care of few of all the other elements. Few elements that we are very, very passionate about is the 1,000 Golden Days package, which will make sure that the couple is well counseled, the mother's nutritional needs are taken care of, micronutrient deficiencies are covered even before she conceives, and then make sure that all 8 antenatal checkups are taken care of in the best way possible. We will ensure 100% institutional delivery and take care of that mother and child's health for at least first 2.5 years. So that would entail a revamp of our primary health care system. And then we also have a health flagship program that is aimed to eradicate 3 most common cancers in the country: cervical cancer, stomach cancer, and breast cancer. For that matter, I'm sure most of our friends here will know that we have pledged to eradicate cervical cancer by 2030, and we are very much on it. As I said earlier, all our eligible girls are well vaccinated for HPV, as well as boys that we have started from year before last. So we will make sure that these cancers are either reduced in incidence to the lowest minimum possible or eradicated from our community. And as we talk about universal health coverage, I think we need to be very clear with the rules, mandates that all of us have to pay. All of us as individuals, as NGOs, as insurance companies, and as global agencies like WHO, and of course, the state. That is the theme of this year's UHC. So we would be very sure, we would be very happy if we can have WHO and other institutions sitting down with us and clarifying on these rules so that we will know exactly what we should be doing and what we want to achieve. As I said, for us, we have not used the word universal health coverage, but under the phrase of basic health coverage, we wanted to ensure that both basic health as well as education remains free for all Bhutanese at all times to come, and that is our constitutional mandate. So with this, not having much to share on the specifics, I'm very happy to be part of this celebration. And I'm also very excitedly looking forward to whatever we can achieve for next one full year, and then joining the team again into celebrating 2023 UHC Day. So with this, I thank Dr. Poonam and your team and all the health experts gathered here. Tashidele, and all the best for the remaining day.
Thank you, His Excellency Dr. Lote Tshering. Now, may I request His Excellency Mr. Rui Augusto Gomes, Minister of Finance, Timor-Leste, to deliver the keynote address on financing mechanism to promote UHC.
Timor-Leste is not only one of the youngest countries in the world, but it is also one with one of the youngest populations. To ensure we reap the advantage of this demographic dividend, our people need to be healthy, educated, and live with confidence. Unfortunately, being one of the highest rates of tobacco and alcohol consumers among Southeast Asian countries, the Timorese, and especially the young people, may not be able to achieve their full potential. On top of that, we will be facing another challenge in the long term. The current oil fields, which have been the main contributor to our revenue since 2005, have ceased to produce. We need to identify other sources of income to keep the economy going by raising domestic revenues. Is there any connection between the two issues? Yes, there is. Health taxes imposed on products that have a potential negative impact on public health, for example, tobacco, alcohol, and sugar, and sweetened drinks. These taxes are considered win-win policies because they do not save lives and prevent disease, but they promote health equity, and they are a great source of financing the state budget. Imposing more taxes on bad products like tobacco, alcohol, and sugar will cause consumption to fall. Academic studies in low-income countries suggest that a 10% increase in tobacco prices is associated with a 5 to 10% reduction in the quantity consumed. And young people are more likely to reduce smoking if faced with higher taxes. If this plays out in Timor-Leste, then we do not expect to see a significant rise in domestic revenue, but that helps reduce heart and lung disease, which is one of our biggest killers today. Considering the advantages of such a policy, the government of Timor-Leste has recently introduced landmark legislation. For the current fiscal year, we increased tobacco taxes by 163%, from $19 per kilogram to $50 per kilogram. And for the next fiscal year, we have doubled the rate of to $100 per kilogram. Also, we have introduced taxes on sugar, $1 per kilogram, and sweetened drinks, $3 per liter. We have also raised taxes on alcohol. These are momentous decisions for Timor-Leste, recognizing that health taxes are pro-poor, pro-health, progressive, and productive. We will engage all our stakeholders to stay the course on this initiative. Health is determined outside the health sector. It depends on where people are born, work, live, and play. To improve health, sectors outside health must work with the Ministry of Health. An example of this is where our Ministry of Finance and the Ministry of Health have cooperated to improve the lives of our people. To conclude, I would like to take this opportunity to thank all our partners and friends, including WHO, for their advocacy and support in this area. Together, we will make Timor-Leste stronger and healthier. Thank you.
Thank you, His Excellency, Mr. Rui Augusto Gomes. Now, I would like to introduce our keynote address series on making health system fit for UHC vision. May I now request His Excellency, Mr. Anutin Charnvirakul, Deputy Prime Minister and Minister of Public Health, Thailand, to deliver his keynote address.
Mr. Prime Minister, Excellencies, distinguished delegates, on behalf of the Royal Thai government, I'm pleased to share Thailand's experience on making health systems fit for the universal health coverage vision here at the International UHC Day 2022. I am particularly enthusiastic to see the theme of the event, UHC We Can. As in Thailand, we have proven that universal health coverage is truly possible, and we take it as our mission to share our lessons to friends in other countries. As we all know, UHC is a key pillar for human development, and UHC is included as one of the Sustainable Development Goals. I would like to take this occasion to have a reflection on what we have achieved during the 2 decades of Thailand UHC and what we are doing to bring to the next level and live up to the title Universal Health Coverage. Thailand UHC is highly recognized by the world leaders. Amartya Sen, the Nobel Prize laureate, said Thailand has proven to the world that UHC is an affordable dream. Ban Ki-moon, the former UN Secretary General, said UHC in Thailand helps protecting people from being poor due to health spending. WHO Director General Dr. Tedros said UHC is not just a dream. UHC is a vision that can be realized, like what is happening in Thailand. What brought us here is the long-standing government investment of health systems and the true belief that healthcare is the basic human rights. Our ultimate UHC vision is to leave no one behind, and that everyone has access not only to basic healthcare, but also quality healthcare, which will be a tangible evidence for social equity. In order to achieve such vision, our health systems must be continuously developed in the direction that enable us to reach more people, be more efficient, and be resilient enough to face with future challenges and crises. Post-pandemic, the Ministry of Public Health of Thailand has since focused on the people. The technology and the expansion of service facilities in both quality and quantity. We use the strength in Thai community for the benefit of healthcare through village health volunteers, consisting of over 1 million volunteers nationwide, who helped us through the COVID crisis by educating community on the disease prevention, encourage immunization, and coordinate for medical support as needed. We now have several programs to enhance their potential as we realize that the preparedness is crucial for public health resilience. Sufficiency in service facilities is also a key to ensure that we will be able to cover all of our population in usual and unusual times. As Thailand is entering the aging society, our universal health coverage benefit package has been extended to cover the needs of the older generation. We also expand specialized service such as kidney dialysis for patients in remote areas. To enable us to reach more people effectively, our telemedicine services serve as the online platform to provide medical support. We have been creating a big data of the National Health Database for all Thais to be able to access their personal health information and for health facilities in all levels to use in order to provide seamless services throughout the patient's journey. These are how Thailand is making our health systems fit for the UHC vision. Ladies and gentlemen, Thailand continues to commit to the principle and the goal of the universal health coverage. It is time for us to empower the global UHC movement again. On this note, I would like to urge you all to support Thailand's proposal, the resolution of the 152nd Executive Board of WHO on the preparation for the high-level meeting of the 2023 United Nations General Assembly on UHC. Let us, the whole region, unite in building a healthier world by investing and making our health systems fit for the UHC vision. Thank you.
Thank you, His Excellency, Mr. Anutin Chand Viraku. Now may I invite His Excellency, Mr. Ahmed Naseem, Minister of Health, Maldives, to deliver his keynote address.
Regional Director, Dr. Poonam Khetrapal Singh, my fellow Ministers of Health, senior officials from the WHO regional and country offices, and Ministries of Health from the region, participants from the federations representing medical and pharmaceutical students. Ladies and gentlemen, Assalamu alaikum, and the warmest of greetings from the Maldives. At the very outset, I would like to recognize the importance given to universal health coverage by the WHO Regional Office and their dedication to raising UHC's profile in this region by marking this day annually. The UHC We Want, Art and Creativity Competition, and the UHC We Have, webinar organized for youth and future health professionals, deserve a special recognition by all members of this forum. As the programs were designed to develop future leaders dedicated to promoting UHC and sustaining UHC gains in their respective countries. I would like to take a moment to congratulate all the young talents who took the initiative to participate in the UHC We Have and UHC We Want. Activities, in particular, the winners of the art and creativity competition, who clearly have the potential to become great leaders in the future, dedicated to promoting a universal health coverage mandate. I am extremely grateful to the Regional Director and her team for giving me this opportunity to say a few words about this year's theme, making health systems fit for the UHC vision and UHC We Want, and making multi-sectoral collaborations and political commitment the focus of this very prestigious event. If we are to succeed in achieving the outcomes envisaged under the triple billion targets, all roads must lead to universal health coverage. We must ensure health services are accessible to everyone in a timely fashion, no matter the location and without having to suffer through financial hardship. Health is a human right and a goal that all governments must strive to achieve for its people. And in this context, I believe the 2019 UN High-Level Declaration on Universal Health Coverage, moving together to build a healthier world, was important to raise the profile of universal health coverage amongst all members. As a result, we have been able to better coordinate country-specific interventions and mobilize resources towards universal health coverage by recognizing it as a regional flagship area and aligning it with our SDG targets. We can all agree that better coordination and collaboration within and across public and private sectors are the keys to making our health systems and socio-economic aspects more responsive towards universal health coverage. Let us not forget the lessons we learned during COVID-19 pandemic, whether it was physical access to health services or community support mechanisms. Health sector is just one small entity in a wider, more complex ecosystem. In the Maldivian context, most of our small island communities do not have the critical mass of people for the private sector to flourish. As a result, the government is the sole provider of health and other critical public services, such as transportation. For this reason, although costly, the only way we have been able to achieve universal health coverage has been by instituting a social health insurance scheme that covers all services and medications provided by government facilities. It gives me great pride that Maldives has achieved most of our universal health coverage indicators and drastically reduced out-of-pocket expenses over a short period of time. Under the UHC policy, all communities, regardless of their size, have a health facility with at least a doctor, nurse, and community health worker, and a pharmacy that provides essential medicines. Access to specialist consultations and more comprehensive diagnostic functions are made available in large communities. Emergency referral services are also fully covered through UHC. Very often, it is the financial burden or out-of-pocket expenses that prevent people from accessing health services in a timely manner. Recently, we have been trying to innovate how we ensure universal health coverage and further reduce the cost of health services on the government and our people. The main focus of this shift in policy are public-private partnerships and revitalization of primary health care. Even at the very early stages, we learned that connecting health to provide private services such as transport, reduced unnecessary expenditure, and improved accessibility to health services, making universal health coverage more efficient and less costly to the people. People who previously had no option but to hire expensive private boats for individual trips can now travel between islands for a minimal fee. The predictability and affordability of pre-scheduled transport services has also increased health-seeking behavior amongst the public. Health facilities now utilize these transport services to transfer medical samples to higher grade laboratories and to conduct outreach specialist services, thereby reducing the need to set up comprehensive diagnostic services at every island and minimizing the need to travel to access specialist services. Another example of a public-private partnership that resulted from this shift in policy in supporting a state-owned enterprise to set up pharmacies on every island in a partnership agreement. Additionally, our policy to revitalize primary health care is seeing a mass reorganization of critical human resources across institutional borders, resulting in the formation of multitasking, multidiscipline primary healthcare teams that operate at island levels, with a bigger focus on engaging with the community to ensure a healthy society. Some key takeaways from the Maldivian universal health coverage experience is health is a human right, and irrespective of socio-economic conditions and financial capacity of individuals and families, the government must facilitate and ensure access to health services in a timely and equitable manner for all its people. Where possible, engage with other government entities and private sector to ensure health service provision is made more holistic. Universal health coverage is only possible with political commitment and through better coordination and collaboration between and across institutions and sectors. Once again, I would like to thank the regional office for their dedication in making the UHC Day annually and thus raising its profile. I would also like to thank Madam Regional Director for emphasizing the importance of political commitment and multiple sectoral collaboration in achieving universal health coverage. I am sure that there is a lot we can learn and replicate from sharing each other's experiences. The government of Maldives is fully committed to improving our health systems through better coordination and collaboration. We stand ready to work with all members of this region to achieve our common UHC goals and targets, both countrywide and regional. Thank you for your attention. Thank you very much.
Thank you, His Excellency, Mr. Ahmed Naseem, Minister of Health, Maldives, for his thoughtful address. Now, may I invite Dr. Vinod Paul, member of Niti Aayog, India, to deliver his keynote address.
Good morning. Honorable Prime Minister of Bhutan, Excellencies, Dr. Poonam Khetrapal Singh, Regional Director, WHO, Southeast Asia Region, distinguished colleagues, I extend warm greetings on the International Universal Health Coverage Day 2022 from the Government of India and my institution, the Niti Aayog. India's journey towards universal health coverage has taken a huge acceleration and push since the time the Honorable Prime Minister Narendra Modi has taken over the reins of this great nation in 2014. Our UHC model rests on primary health care. A commitment was made in 2018 to develop a network of 150,000 Ayushman Bharat Health and Wellness Centers across the nation, and we are on track to achieve that. At the last count, 133,000 such health and wellness centers have been established. This is an upgrade of our primary healthcare services to a totally new level. These centers are connected through telemedicine. These centers are expected, sub-center health and wellness centers, for example, are expected to have 105 drugs. The ones which are primary health center are slightly higher above this, have 172 drugs and medicines. The sub-center levels have 14 diagnostics, and PSC level health and wellness centers have 66 diagnostics. This work will ensure that we are able to deliver 12 comprehensive primary healthcare packages through the system of the health and wellness centers. India has made significant and dramatic progress in the sphere of human resources for health, the other building block of the health system. Since 2014, the undergraduate seats in our nation have doubled from 52,000 to close to 100,000. The postgraduate seats have again actually more than doubled. We moved from 30,000 to above 62,000 postgraduate seats. We agree and we believe that although the WHO doctor-patient ratio, doctor-population ratio is within our grasp, and if we add our Ayush practitioners, we already have 1.5 times of that ratio, but our journey toward ensuring enough number of specialists is still tough and long, and we're working feverishly in that direction. I'm also very happy to state that as we move forward, we see a synergy between the traditional systems of medicine of India and the modern healthcare system of our nation. Our flagship program, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, is aimed to provide secondary and tertiary healthcare cashless and paperless, almost entirely paperless, for a population of 500 million people of India. 50 crore people of India are health assured for secondary and tertiary care system. We have had this journey for the last 4 years, and we have seen 41 million hospitalizations under this program. And this program is gathering steam, and we are hoping to extend linkages of this scheme with our employees' social insurance system, and also deepening its reach to the people where we still have to make more effort in some states in particular. I'm also very happy to state that India launched Ayushman Bharat Digital Mission. India has a special strength in digital health, and we are on a roll having launched the Ayushman Bharat Digital Mission last year, under which there are 5 components: the electronic health records, telemedicine, doctors' registries and health facilities, and also an ecosystem that connects us all. I'm happy to state that using this system and beyond, in the wake of COVID-19 in particular, more than 76 million e-consultations were made through the government telemedicine system. That's just the government one. And many times this have happened in the private and state level systems. So India is giving a great push for telemedicine. We were happy to have created telemedicine legal framework just before COVID-19. It was ready, and we believe there are elements that are useful for creating such legal frameworks for safe, trustworthy, privacy protected telemedicine system in other countries like we have done here. In terms of infrastructure, under Pradhan Mantri Ayushman Bharat Health Infrastructure Mission and the allocation from the 15th Finance Commission of India, we are looking forward to investing 20 billion USD for infrastructure in these 4 to 5 years, coming 4 to 5 years. This is, of course, in addition to all the other programs. This is a new program. India looks forward to strengthening health infrastructure through private investment as well. We are moving in the direction of inviting a very large presence of medical value tourism into our country. And we need public health system for our own nation, private health system connected in a seamless way for our own system. But also we believe that India has a great potential to offer for patients who come from countries where certain types of care may or may not be optimally available. In terms of prevention, I'd like to mention that India has built since 2014, 109 million toilets. All our villages are ODF, they're open defecation free. India has provided 94 million LPG gas connections to reduce the misery of households, as well as to provide clean air. And India is moving rapidly in the direction of providing potable, safe water through tap to rural households. At the start of the program, 3 years ago, only 17% households in rural India had such water supply in their homes. We've already moved to 52.5% or more of such supplies being available. These elements will ensure that India's health system and healthcare is increasingly much better. I like to offer in the end 4 areas where India has a strength, and we believe we extend our cooperation and our capabilities to the region and to the world. 1, pharmaceuticals, vaccines, and medical technologies, including diagnostics. Huge presence, huge capacity, and huge future. We would like us to be guided by WHO and other nations of the region as to how we can work together, that it's a win-win situation for our region and the world. Number 2, India offers its collaboration in the sphere of traditional medicine. We are so grateful to the World Health Organization and to DG, Dr. Tedros, to have located the Global Center for Traditional Medicine in India. And we wish to use that opportunity and that platform for expanding the reach and the alignment of traditional medicine of all countries, including India, for the larger benefit of the society. Number 3, we have, as I said, strength in digital health, and our technologies are globally known. The last big one that came on the global scene was COVID, which provided us a platform for more than 2 billion doses of vaccine in a seamless way. We'll be very, very delighted and honored to extend our cooperation in the sphere of digital health. As the Honorable Prime Minister steers the G20 presidency, India emphasizes and reaffirms its commitment to global health, its commitment to universal health coverage, and to carry that out through the principles of whole of government, whole of nation, whole of society, and whole of global society approach is the way forward for us. Thank you very much. Jai Hind.
Thank you, Dr. Vinod Paul, for your insights. Now I would like to introduce keynote address on parliamentarians for UHC. I would like to invite His Excellency Mr. Gagan Thapa, Member of Parliament, Nepal, who is joining us virtually to elaborate on how parliamentarians can contribute to the UHC.
Thank you. First of all, I would like to thank Dr. Singh for inviting me to address this STEAM gathering. Excellencies, distinguished delegates, colleagues, ladies and gentlemen, it is a great pleasure for me to be a part of this important event. You. There's so much for the well-being in our region. Experiences we have holding universal health. I think is one of the resources without cost. It stipulates rights.
Since we're having some technical issues, I think we can first we can start with this special lecture on health systems reform, do's and don'ts. He's coming. Okay. Maybe we can hear him again. All right, we're going to try this once more. Can you unmute him, please?
Okay. I'm sorry. Our federal grants local governments significant autonomy and responsibility to ensure healthy individuals and communities. We make our health responsive and people. When I was appointed, I focus on translating aspirations into reality. My tenure in
All right. Apologies for the technical difficulties. While we are figuring that out, may I introduce the special lecture on health systems reform for UHC do's and don'ts. For this, may I invite Dr. Somsak Chunaras, President, National Health Foundation, Thailand, and former Deputy Minister, Minister of Public Health, to deliver his remarks.
His Excellency, the Prime Minister of Bhutan, dignitaries, Dr. Punam, and distinguished guests. It's an honor for me, and I hope that I will be sharing some of the lessons on health system reform, in particular, as Dr. Punam, the Regional Director, has mentioned. The three important elements is how to get the whole government for health. Of course, it will help UHC a lot, and as the Prime Minister of Bhutan has alluded to, healthcare system is the core of UHC, but it can also do the third thing, which is community participation in a much more powerful way to make sure that health is the ultimate outcome of what we are trying to do. Of course, I was asked to talk about do's and don'ts, so I have to be very careful because things change all the time, and they are chaotic and unpredictable. So whatever I said as do, maybe don'ts. What I said as don't, maybe do. So maybe you should be careful with what I'm going to share with you. But that's the nature of chaotic world. So there's no absolute do's and don'ts. And as we know, they say the healthcare system is a complex system, and complex system has two important characteristics. There are many characteristics. One is that it leads to unintended consequences. Whatever you did, may give you a lot of surprises. On the other hand, it has the emerging property. Something new would come up when things interact. Actually, even hydrogen and oxygen interact to become water. Two gases become something watery. So, you can expect lots of emerging property from a complex system. So, in every do's, there will be don'ts, and every don'ts, there will be do. So, what I'm going to share with you would be, some starting statement with do or don't. But be careful that in between, there will be lots of don't in the do and many do in the don't. Let me start with the first one. I have 10 10 points, there are so many other things to say, but I'll just try to be brief on what I see as essential things, having worked on UHC in Thailand, at least over the last 20 years. And as Prime Minister of Bhutan has mentioned, working in the healthcare system in Thailand over the last 4 decades before my retirement, and seeing healthcare system evolution as a very important part of UHC. And of course, into the future as well, not only from the past, but the UHC posed a lot of challenges. COVID posed even more important and interesting lessons and challenges for healthcare system reform into the future. Of course, the first issue is about governance reform. And if you look at the 3 components and the UHC goals and the SDG goals, you see at least 3 different aspects or different types of governance that need to be synced. The synchronization with 3 important governance. The governance for health by all sectors in the government, multi-sectoral collaboration is one. We are not successful very much in Thailand yet, not yet. The second, of course, is the governing of the healthcare system itself. And Ministry of Health has been doing great jobs in many of our countries in the region and in many other regions. But the third part is the governance for healthcare financing, because UHC promised to protect financial hardship. But again, proper and adequate investment for health would be an important part. And it might be a very specific and very dedicated types of issue to be considered apart from the multi-sectoral or the multi-ministerial governing mechanisms for health. So ensuring adequate financing for health is definitely another level. And again, if I go back to Thailand a little bit, we are still struggling with that. But maybe more important about governance reform is the fact that we need to make sure that it is participatory in a way. At least in the case of Thailand, the so-called UCS, which take care of the majority of the population, the governing mechanism is participatory. We have lots of NGOs and civil society members in the board which make policy decisions, not only providers or Ministry of Health or Minister himself, because we want to make sure that it reflects some kind of needs from the people themselves. But the other thing beyond participatory is evidence-based, using knowledge. And of course, the last part, very important, is ensuring accountability and dynamism. In other words, whatever you make decision, people have to know. They have to be able at least to check and to ask questions. They may not have to agree with them because somebody has to make decisions somehow. But at least make sure that whatever decision you make is, of course, feedbackable. That would be my term. The second point is that if you come to healthcare system, I think one important lessons about healthcare system with UHC and again post-COVID is the fact that you need to build health system based on primary healthcare to mean that care systems are interlinked across levels and over time. And by across levels, as we have been alluding to, Dr. Poonam in particular mentioned about community empowerment. The healthcare system has to be able to work with community. In Thailand, we call that community health systems, just to mean that there are other key actors in the healthcare system that the healthcare providers, the professional, have to be able to work with. That's definitely a challenge for many of us. But one of the things that I believe would come with that is that you have healthcare system which can have what you call population and geographical coverage, so that you know whom to work with. Because if you don't have geographical or population coverage, you don't have key stakeholders to work with, and you cannot create very good community health system. But the other part that I believe we all see, in particular during COVID, is the interlink across levels. Not everybody can go to hospitals and meet specialists. In COVID, we have a lot of home isolation, very much home care, which need to be attended to, but at times they need to be referred to hospitals. If you have a good interlink, that would be great. Of course, in chronic diseases, chronic conditions like today, interlink for continuity of care is even more important. It's a back and forth referral even, again, over time, not only for a particular time, only. So, I quoted the report from WHO about the people-centered healthcare system, as Dr. Poonam has mentioned. Strategic direction number 4 is coordinating services. The challenge, of course, is coordinating with private providers. And in UHC, we use a lot of private providers, healthcare providers. I'm not talking about the non-healthcare providers, such as boat riders or whatever that our Minister from Bhutan has mentioned about, which is very important. That is also very, very important. The third point is that, at least again, the lessons is that if in a healthcare system, in particular in the public sector, do we have what I call subunit autonomy to rethink and redesign care delivery models? Because in the future, you cannot depend on centrally design or fixed design for care delivery. Context changes, and of course, needs also change. So it will be very important to have subunit autonomies. I always refer this to our particular experiences in Thailand. The public sector has what we call subunit autonomy in financing and human resources a little bit, increasingly so. 60 years ago, because one of the Minister of Health happened to be dealing with the Minister of Finance, who agreed that, at least healthcare system could collect revenue and make use of those revenue. Of course, there will be rules, there will be accountability check, there will be monitoring. It's not free hands. But at least that has made the healthcare system at the rural level, at the district, sub-district level, more autonomous. Again, with the UHC and the lump sum payment, the subunit autonomy has also been reinforced. But again, I emphasize that accountability check has to be there. Otherwise, there will be lots of questions. When I talk to colleagues in different countries, talking about these particular experiences, they always ask whether there are corruption. Yes, there were corruptions. But of course, because of the accountability check, you decrease that gradually. And with the expanding human resources, with the increased awareness and active citizenship, those things have become, I think, almost gone. Of course, the next point that I believe we all share is building public trust. Everything has to, in particular, when we talk about health system based on primary healthcare, because people don't see primary healthcare as we saw it. We wanted to have the interlinked system. We don't just have the primary healthcare, the poor people, the poor workers in the primary healthcare work on their own just to take care of simple diseases. Nobody will trust someone who can only see them for simple conditions. They want someone who can take care of them, even though they are seriously ill. Of course, you don't have the technical competencies, but you have the linkage, you have the credibility, you have the mandate to do that. So that one of the ways of building trust. I quote, maybe we should try to do ABCD. Of course, make the system attentive. I don't like the word responsive, because I still think it's still too reactive. I like the word attentive. You have to give attention. You have to show them that you care. The second thing is that you have to be believable or credible. They have to know that you are dependable. The last one, and of course, in between, you have to be consistent. Don't just do it for some time and then fall asleep most of the time. The next thing about do is monitoring closely. Monitoring, we talk a lot about monitoring. For me, the monitoring part, which is important, are two things. We monitor to improve, not to criticize. And we monitor to learn, not to punish. Many of the monitoring systems seems to be emphasizing on criticizing and punishing. Even the reimbursement system in the healthcare financing, in the new healthcare financing system in Thailand, seems to have that problem. But we need to monitor to make sure that we find rooms for improvement, we find gaps. The other part that I think would be important about monitoring is that we monitor how people feel, how people see. Satisfactory survey is one part, but maybe it's not enough. There's a complaint system. And I said that complaint systems work like a surveillance systems. The moment you ignore the complaints, it could escalate and lead to outbreak. So maybe we should treat our complaint system just as we treat the disease surveillance system. Be responsive, rather than just getting to know. There are so many other things to say about this part about people satisfaction, because if you believe in Yuval Harari, three reality, I'm sure that Yuval Harari, a very interesting Buddhist Jewish philosopher. He said that there are three types of reality to the world. The physical reality that everybody experience. We know, we feel the same about the physical reality. Climate change is one example. Second is your personal subjective reality. Nobody can know that reality except you. And of course, the third one is a shared imaginative reality, such as language, banking system, money. Anyway, the second type of reality is something that we need to be able to get to know of, at least in terms of suffering, as we all say. Otherwise the equity dimension would not be too well addressed. COVID is just another example. Because we don't have information system, we don't have ways to know how the poor people feel or suffer. We just control diseases without ideas of how they are doing. And maybe at times we do a lot of things at their expenses. But anyway, I'll stop there. There are so many other things to talk about monitoring. I just wanted to make sure that we are not talking about technical data-driven monitoring only. We're talking about monitoring feeling and perception. The other thing that I like to propose in terms of do is to emphasize on human resources motivation and support them to work for value, personal value as well as collective values. Human resources for health has been very much emphasized, but I always say that if you look at the two major driving cost drivers in the healthcare system, is technology and salary, payment for human resources and technologies. And technology has been very much, worrying in a sense that they may not be as cost effective. Maybe we should pay more attention to how we could use human resources to replace many of the technologies utilization. In other words, good human resources know how to do to the people in terms of good health, rather than just prescribing drugs or ordering tests. So human resources motivation and support them to work for values would be very important. Of course, in UHC, again, the private sector would be something that we need to talk a lot more about, but I'll come to that later. For the public sector, I believe that, maybe we should not, no country could afford to pay private providers as high as private provider. Thailand is also another good example. There are always gap. I could tell you a lot of my experiences. I start with 4,000 baht a month. I retire at 80,000 baht a month, 20 times more. But the gap is still very high. So you have no way to close that gap. But maybe financial compensation is not everything. Maybe if they feel that they have been doing good things and they feel that they have been treated fairly, they feel that they have the chance to contribute ideas and to be, to make some decisions. These are the three important things that might be very encouraging for them, rather than just trying to find a way to pay them. Of course, you have to be able to make sure that you meet their basic financial requirement. Again, that's the issue that needs to be tackled. Now I come to the four don'ts at the end. Don't rely on money. Again, UHC emphasized a lot on financial risk protection. Many countries go to the extent of having the so-called purchaser-provider split. And we believe that if we use the financing tools good enough, you change provider behavior, you change people behavior. But financing tools is not everything. It's a starting point for many other things. And if you keep on, having different rules, different ways, you are second guessing how others could do. And they will always have their way around to get the money without doing what you expect them to do. I think that's a very, very important part. In Thailand, we started to talk about not using the word purchasing 5 years into the UHC without great success. we still have to learn a lot how to make sure that we go beyond the so-called purchaser provider split mentality. But again, we have to also find the effective way to use a financing mechanism. Sometimes, I don't want to go into too much detail, but you might like to learn about that. For example, we talk about lump sum payment versus unbundling and bundle payment. All these terms are very, very useful. But many of these practices seems to erode on provider autonomy. So maybe they lack the incentive to innovate and to change things, to redesign things. If you use a financing mechanism too rigidly. So I think that would be one of the key message. The second don't is that don't just buy services from private sector. I just use the word buy services in brackets because maybe we just again see them as providers whom we can buy whatever services. Important thing is that we need to create partnership. I think as the Minister of Bhutan, Maldives have mentioned in many examples, building partnership means agreeing to reach a higher goal through mutual benefits. There are many other things to say about don't just buy services from private providers. But the key thing is that private provider is also not very much into what we call primary healthcare, into what we call preventive promotive services. But it doesn't mean that they don't want to do that. I'm sure that India has a lot of good examples to share with other countries because many of the private sector in India has been very innovative and of course help to cross-subsidize the poor population. And I believe that there are many ways to have that kind of a private partnership. But again, we also wish that private partnership or private provider would be also more proactive approach, working with the community rather than just waiting in the hospitals. But for that, the public sector need to help by giving them some boundaries, some population to work with, some authority to at least engage in talking to the other key stakeholders. In Thailand, again, we when we went back to our laws, it seems that most private sector cannot do that. They can't even go out of their clinic or the hospital to provide care. At least in the Thai context. Of course, we have to change that because in the old days, we were too concerned about so-called poor quality or exploitation of the public. Again, the next one is that don't build digital transformation from top down. Dr. Vinod Paul has talked about India attempt to use IT. I think that's a very important part. In Thailand, we have been trying to do many things. Dr. Kun Anutin mentioned about telemedicine as well. But one of the lessons that we learned is that if you build only infrastructure, if you build only the system design, if you build only tools, maybe the people who are supposed to use them do not have enough capability. Electronic health records used by individuals has been one of the dreams in many of the healthcare systems through digitization. But one of the important part is that how could they make good use of that? Even in the healthcare system, when we improve the health information system, they rarely use existing system for their own purposes. Many of the system has been built for reporting purposes, from reimbursement purposes, although they could be used very much to improve clinical care, to improve facilities management. So within this don't is that emphasize on peopleware and make sure that people, the providers, the people in general understand the power and the usefulness of all these digital tools, all the information generated through the new digitized information systems. Of course, my last don't. Again, I had a mixed experiences of being a technical person as well as in politics for a short while, but engaging a lot in policy process over my 25-30 years in the Ministry of Health as policy analyst in the planning division. I think when you come to UHC, many politicians, political parties saw the opportunities of making them, gaining them votes. I think it's everywhere. It's everywhere. I had the chance to meet with the Minister of Health of Turkey, who started the UHC in Turkey more or less the same time as Thailand started. He said that, in the beginning, before the election, his policy is not very much taken seriously by the government as a whole. But after the election, people benefit from the policy, and health minister, health system became one of the top priority. So I said, wow, lucky to you, because Julio Frank, another good friend of us in Mexico, doesn't have that chance of having support from the whole government as much as what they had in Turkey. But the point is that when you see success, you seem to want to do more. And many of the times, when I say populist, I mean something that you promise that are unrealistic and unsustainable. We can debate when we made that decision, whether that thing is unrealistic and unsustainable or not. We can debate a lot. But the point is that we need to be careful. At least. Decision, again, going to the complex system. When you made a decision, you never know. I think we had good examples on 2 examples, antiviral for HIV, and of course, dialysis for end-stage kidney diseases. We decided not to have it in the beginning. Only after 5 years, we have both. Now we are worrying about some of the so-called potential increased costs. Somebody projected that the dialysis would take 10% of the total UHC budget, which would be very alarming for many of us. But the point is that we need to do 2 things. We need to at least talk to decision makers. And at least we need to talk to the public as well. Because public also has their expectations. And public expectation is always the key. Maybe we need to be able to manage public expectation even more. So I'd like to conclude by saying that these are just some of the points that I hope would be useful for us to move forward in terms of healthcare reform. Many of the things are happening in different countries, but we still need to do more. It reminded me of my teacher, the founding dean of Ramatipati Medical School, Professor Ari Valayasevi, who has just passed away at the age of 96 a few months back. He told us that when he was a student in the US, he always did homework and sent it to his teachers. And his teacher is always criticizing him for not doing good enough. And he said that, I have tried my best. So the teachers say, well, your best is not good enough because you can always do better. Not because it is not good enough, but because you can always do better. I believe that we all believe so with our UHC movement. It's a long march. We have done a lot, but a lot is not enough because we can always do better. So I wish you the strength and the force to do things better and better for the benefit of our people in our own country, in the region, and in the world. Thank you very much.
Dr. Somsak Chunaris, President, National Health Foundation, Thailand. Now His Excellency Mr. Gagan Thapa, Member of Parliament, Nepal, has joined us virtually. So I would like to introduce the keynote address on parliamentarians to UHC and request His Excellency Mr. Gagan Thapa to elaborate on how parliamentarians can contribute to UHC.
Thank you. Sorry, we had some connection issue. First of all, I would like to thank Dr. Singh for inviting me to address this STEM gathering. Excellencies, distinguished guests, panelists, colleagues, ladies and gentlemen. On today's topic, I'd like to share parliamentary experiences we have had in Nepal on upholding universal health coverage. Our constitution, promulgated in 2015, ensures that healthcare is a fundamental right of every citizen. I think ours is one of the most progressive constitutions in the world to underpin universal health coverage. It guarantees access to basic health services without cost. It stipulates rights to clean air and water. Every woman has a right to their reproductive health. Our federal framework grants local governments significant autonomy and responsibility to ensure healthy individuals and communities, which provides unprecedented avenues to make our health systems responsive and accountable to the people. When I was appointed Nepal's health minister, I focused on translating our constitutional aspirations into reality. During my tenure, we spearheaded many reforms, including drafting a bill to enact social health insurance, which later became law. We enacted policies to take healthcare into people's communities, particularly in urban areas that face significant gaps in primary health services. I believe in placing individuals and communities at the center of our health system design, where healthcare reaches every individual in every home. My ministerial tenure was also a humbling experience. I witnessed firsthand the challenges we face in realizing our constitutional aspirations. In Nepal, we lose more than 1,500 young women during delivery every year, and 34 babies die every day before reaching 30 days of life. Pregnancies and childbirths are a celebration of life, a celebration of womanhood and motherhood. However, for many families in Nepal, pregnancies and childbirths are risky propositions, a gamble of life and death. Every year, 23,000 children die in Nepal before their 5th birthday. Among those that survive, 1 in 4 are malnourished, dampening their physical and cognitive abilities throughout their life. The glossy reports and publications in the health sector never fail to praise Nepal's past efforts to decrease mortality rates and ratios. But each woman that dies during delivery or each child that faces early death is one too many. These are real people that we lose: mothers, children, sisters, brothers, and friends. We must do our utmost to protect every life. We must recalibrate our health system to value every life and not see people's lives and health as mere statistics and trends. People's feelings, struggles, and stories should not be lost amidst our discussions and figures of mortality rates and ratios. While access, quality, and financing are necessary guiding principles for our health systems to advance universal health coverage, our systems and institutions must also be guided by empathy. As lawmakers, we must adopt an all-of-government approach in tackling our challenges in health. We must recognize that many factors shape our health. The health of mothers directly influences the baby's survival and their physical and mental development into adult life. The environment around us, the air we breathe, the quality of water in our taps, the physical infrastructure surrounding us, the quality and variety of foods in our markets, the nature of our jobs and professions, our habits and behaviors, and of course, health intricacies. We'll have trust. Citizens' voices are critical in shaping UHC, but we need to listen more to them and communicate more with them. I have found many in my own constituency who are unaware of their health entitlements and the state's health provisions. Citizens need a clear pathway to provide feedback or voice their needs, which is lacking. We need to catch up on the importance of people's need in our UHC discussions. We have discussed the UHC in Geneva and adopted it in New York, but we have yet to discuss it with our own public. As taxpayers and users of the system, their needs and aspirations should shape our decisions. Unfortunately, ladies and gentlemen, I cannot confidently claim that our health system in Nepal are tailored adequately to meet the need of our citizens. As a result, our public health sector faces a crisis of confidence. The people are losing faith in the government's ability to address their health need and its commitment to improving their health. We cannot afford to continue investing in health systems people do not trust, value, or underutilize. We must rethink the design of our health systems and overall our institutions and approaches. This remains my priority for the next decade. In Nepal, the UHC discourse is yet to sufficiently reach our politicians, democratic institutions, and the larger public. Despite recent rhetoric on intersectoral action, most government-aligned agencies are yet to espouse the UHC in their strategies and activities. In reality, UHC very much remains an internal agenda of the Ministry of Health. However, solutions to the urgent and pressing health challenges we face today do not exclusively lie in our health ministries alone. We know that when women have opportunities to access education, they are significantly more likely to survive childbirth and more likely to have healthy children. Our agriculture and food systems have a direct influence on our nutritional needs. We can only curb road traffic accidents with the leadership of the transportation sector. Despite knowing the importance of a whole-of-government approach, and even after putting in place multi-sectoral plans in areas such as nutrition and NCDs, we have struggled in Nepal to harness collective action among different sectors. As parliamentarians, we have levers at our disposal to anchor different government line agencies to advance UHC. We can hold the government to account, but for ourselves, we're accountable to the people. Therefore, we are also well positioned to engage in public debates and discussion about the importance of UHC. Ladies and gentlemen, we cannot advance the UHC without political commitments, and we need more parliamentarians to champion UHC and its broader ambitions. I recently established a new model of urban health facilities in my constituency. I'm encouraged by the willingness of many political leaders to replicate the model in their respective constituencies. I'm working on galvanizing our parliamentarians and political leaders to establish health as a prominent political agenda and rekindle the political spirit to realize the health aspirations of our progressive constitution. In this journey, I need support from the health experts, care providers, government officials, international partners, and most of all, from our people and communities. Let us work together on this noble goal. Let me end with a quote from Professor Amartya Sen's keynote address to the 52nd World Health Assembly. Development has to be primarily concerned with enhancing the lives we lead and the freedoms that we enjoy. And among the most important freedoms that we can have is the freedom from avoidable ill health and from escapable mortality. Thank you.
Thank you, His Excellency, Mr. Gagan Thapa, Member of Parliament, Nepal. Now I would like to request RD Madam on stage to give token of appreciation to our speakers and panelists. May I now request Dr. Vinod Paul, Member of Niti Aayog. Now I would like to invite Dr. Somsak Chunaras, President, National Health Foundation, Thailand. Now I would like to invite Dr. Thula Siraj Ravilla, Executive Director, Arvind Eye Care System, India. Now I would like to invite Dr. Ratna Devi, CEO, Daksham Health and Director, Patient Academy for Innovation and Research, India. Now I would like to invite Dr. Manoj Fernando, Department of Health Promotion, Faculty of Applied Science, Sri Lanka. Now I would like to invite Ms. Tanushri Jain, representative of International Federation of Medical Students Association. Now I would like to request everyone to, the speakers and panelists to join for a group photo. Oh my God. Thank you to all our speakers and panelists and RD Madam. From here. Now I would like to invite Ms. Tanushri Jain, Chairperson of Good Pharmacy Practice Education and co-host of the webinar of UHC We Want, to provide us with summary of the webinar held on 8 December 2022.
A very good morning to all the dignitaries and distinguished guests present here. I'm Tanushri Jain, representative of the International Pharmaceutical Students Federation, here to report on the webinar UHC we have conducted on the 8th of December 2022, hosted by WHO Sierra along with IPSF, IFMSA, and People's Health Movement, with the objective to promote engagement and ownership of youth and future health professionals in the region for the operation of universal health coverage. Ms. Varanan, researcher at the International Health Policy Program, Thailand, delivered the keynote speech for the webinar. When we talk about the three-dimensional approach towards UHC, it ensures asking the three questions: who is covered? What do people have to pay out of pocket? Which services are covered? And then ensuring movement to fill in the gaps identified. Sustainable Development Goals commits to achieving UHC, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all by 2030. By 2023, the goal is benefiting 1 billion more people from UHC. Before the pandemic, the shortfall was estimated to be 730 million. Now it is close to 840 million people. In the Asian continent, some countries like Japan, China, and Thailand show high coverage, and yet many countries, particularly in Southeast Asia, show low coverage. Significant progress has been made since the year 2000, but at this rate, it will not be fast enough to achieve over ADC by 2030. Although more people can now access health services at the same time, a lot of them are under catastrophic financial burden. COVID-19 pandemic interrupted the health services, and now the healthcare workers face the challenge of building back the rhythm. The unique caveat in Southeast Asia is that rather than the human resources, 90% of the health expenditure goes to pharmaceuticals. We need to address these concerns in order to prevent 300 million more people from being pushed into poverty. Also, there is an urgent need to approach our heads of states to allocate more budget to healthcare, which currently is the lowest in this region. The three major points of the discussion were about vulnerable populations, primary health, and financing. One of the biggest challenges to achieving UHC is to find new ways to reach the vulnerable populations. Primary health is also a very important component, emphasizing community empowerment and social accountability. It can bring together different services for communicable diseases, for women and children's health, address the demographic epidemiological challenges, and leave room for innovations such as digital health. A lot more investment is needed towards the global health workforce for a better healthcare system. When it comes to the role of future healthcare professionals to promote UHC, the first is by being active participants for advocacy at local, regional, and global levels. It has been estimated that there are 1.8 billion youth that should be and can be targeted to act as accelerators to achieve UHC by 2030. The second initiative is by ensuring professional and public awareness of UHC among youth. Programs that future health professionals currently conduct are community education and social media campaigns. We also have to give priority to how our future healthcare professionals are able to share their data and also track their outcomes within each of their youth organizations among different professions, such as what IPSF and IFMSA are currently doing. Lastly, we have the involvement of youth in professional initiatives for UHC. In a nutshell, the young healthcare professionals are the future, where they will ensure that UHC becomes a reality for the 8 billion people on this planet. Thank you for listening. It is the voice of the youth that has been represented today.
Thank you, Ms. Tanushree, for the succinct information on the webinar. Now, may I request all the audience to get ready and follow the Energizer on Southeast Asia Regional Flagship.
Hello, we are. Please stand up and follow our moves on this song about Southeast Asia Regional Flagships. But do you know how many flagships there are? 10, 100, billion.
8 flagships, 1 region for the health of feeling. Sustain, accelerate, innovate, and act. Southeast Asia's 8 flagships. Flagship 1, sweet. Flagship 7, eliminate NTT. Flagship 8, flagship 8, and we are ending TB. Flagships, migration for the health of human. Sustain, accelerate, innovate, land. Southeast Asia is a flagships. Where the vision is free. Flagship 2, flagship 2, we are building LCD. Undefined mortality. Flagship 4, flagship 4, for a stronger UHC.
Thank you all for participating in the Energizer. Now, thank you, everyone. Please be seated. Now I would like to introduce the multi-sectoral panel discussion, Breaking Silo for UHC. For this session, I would like to invite Mr. Ibadat Dhillon, Regional Advisor, Human Resources for Health, to moderate the session and invite all the panelists to be on stage.
Thank you, dear Madam, excellent dignitaries. I don't think I have to repeat the importance of multi-sectoral participation, whole of government, whole of society. I think reflecting on Professor Somsak's presentation, two things became clear as I'm inviting the participants. One, how much of values have driven your partnership on UHC. And second, how you have been doing and learning and doing. So please, I would like to first invite Dr. Tulsaraj Ravilla. Dr. Ravilla is a founding member and executive director of Aravind Eye Care System, which he has been leading for the last 4 decades and has built into one of the largest providers of eye care in the world, and spanning not just treatment, but also rehabilitation and prevention. I would also like to invite Dr. Ratna Devi. Dr. Ratna Devi is the CEO and founder of Dakshama Health and Education, which aims to support patient community advocacy, engagement, participation. She leads a cross-disease patients alliance in India called the Indian Alliance of Patient Groups. She is a board member and recently served as the chair of the board of the International Alliance of Patients Organizations. I'd like to invite Dr. Manoj Fernando. He's a senior lecturer in health promotion at Rajaratha University in Sri Lanka. Dr. Fernando, his work is critical because it bridges the often silo between academia, operational implementation, and community engagement and impact. Thank you, Dr. Fernando, for being here. And finally, joining us virtually, please have a seat. Finally, and joining us virtually is Dr. Asif Saleh, the Executive Director of BRAC, Bangladesh Rural Advancement Committee. The superlatives related to BRAC and Mr. Salah do not need to be mentioned, other than BRAC just celebrated its 50th anniversary alongside the 50th anniversary of the nation, and has grown to be the largest non-governmental development organization in the world. So perhaps I will start with Dr. Sala. Dr. Sala, if you are there, you are responsible for overseeing an institution of unimaginable scale and size with comprehensive focus on social development. Could you reflect on the main achievements and challenges towards progressing towards universal health coverage in Bangladesh? Over to you, Dr. Sala.
Thank you so much, and really appreciate inviting us to this esteemed panel. Yeah, I mean, I got the last bit of the discussion in the previous panel, and I think there was the Nepalese Honorable Minister, he quoted Dr. Amartya Sen about how the issue of poverty is intricately related to freedom, choices, and about realizing potential. And I think essentially one of the first sort of learning and practice of BRAC was very much that essence, that all the issues are actually interconnected. And when we started looking at poverty, we started looking at how interconnected the issues of health, education, livelihoods they are. So as a result, you know, even though we started as a relief organization, but over time, as we were starting to look at other issues, the organization grew. And thank you for mentioning that we are celebrating the 50 years of BRAC. But I think one of the key learnings for us has always been that unless you sort of keep people and their issues and challenges at the center of any solutions, it doesn't work. And then the second thing is essentially for complex problems, for particularly resource-constrained countries like ours, you have to come up with simple solutions that are scalable. And I think, I was mentioning about the interconnectedness, and that is the essence of multi-sectoral approach to UHC, is that when, just to give you a very quick example, is that when in the late 70s, when we started going to household levels and talking about poverty and why women do not come out of their households, what they said that we have too many children. When we asked that, why do you have too many children? They said that we don't know how many will survive. And so then our first challenge became that in order to get women out of their households, in order to sort of help them realize their potential and also the household from poverty, you need to basically ensure that child mortality is reduced, because that's where the first step starts. And this is where this whole sort of simple solution in terms of oral rehydration therapy and going to every single household to teach mother how to make them and to use them when a diarrheal disease happens to the children. That started happening, and essentially that gave us a lot of confidence that, you know, you don't need a huge amount of infrastructure and sort of super trained workforce to deliver simple solutions. I think it's very essential that how you can train up some of the most informal sort of women to and basically routinize some of these tasks and be very clear about communication campaign, and at the same time you're monitoring and all of the sort of, as long as you're outcome focused, you can come up with simple solutions, and not only that, deliver at scales. So hence, there are some key lessons from this for UHC. I would say that for universal healthcare, there are 4 critical components that we often talk about. That one is that you need adequately trained health workforce. You need to boost health information system. You need good governance and good accountability of the system. And I would say kind of coming out from a backdrop of the pandemic, once a century pandemic, and some of these have basically highlighted been again. And we are, if you tell me that where are the opportunities and where are the challenges, I would say the challenges lies with good governance and accountability. And this is where I think I want to echo the minister that, you know, the political commitment and political willingness is so important, right? So this is outside of the control of non-governmental organizations like ours, unless like the voice comes in, there's a strong sort of voice comes in from the citizens. It's very difficult to ensure that. But let me focus on the opportunity bit, because that's where I think the solutions lie to a large extent, at least to a number of problems on the UHC side, which is around trained health workforce and the health information systems. And I was also quite heartened to hear the summary from the youth sessions, which also highlighted some of these elements. I think there are incredible opportunities right now with the improvement that is happening on the data space and technology information system space. And if you can pair that up with a trained workforce, that can actually alleviate a lot of some of the major challenges. So if I basically come down from the perspective that core sort of a strong healthcare system requires a very strong primary healthcare system, and we want to prevent people from going to the tertiary centers. So you need to ensure that your sort of the role of the community healthcare workers are so vital. And essentially, I think I gave that example of ORTS because I think we still within Bangladesh manage this very large group of community healthcare workers across the who we have almost 43,000 of them. But the big change that has happened in the last 20 years, and particularly the last 5 years, which came really handy during COVID time, is that we have significantly upgraded their capacity in terms of their digital abilities. So we have kind of basically armed them with the tabs and also trained them in terms of how to sort of use decision trees. So I think essentially one of the key things I would say that the role of community healthcare workers are getting marginalized, I think, for the wrong reasons. I think essentially we need to look at them, but basically a digitally enabled healthcare worker who can work as an intermediary not only solves the issue of access to some specialist services, but at the same time, as we are getting into these newer challenges of this shift that is happening in terms of towards NCD and other things, there are incredible opportunities in terms of collecting the data and at the same time mining the data and providing very specific guidance towards these healthcare workforce. Because let's face it, that in our communities.
Thank you, Dr. Saleh. It's a very important point. I think I will re-emphasize your point about listening to community voice, engaging community, including community health workers. And I think it makes a nice bridge to Dr. Devi, who is a leading voice for patients and communities. Dr. Devi, could you reflect on the role of patients, of communities, of civil society in advancing universal health coverage and associated challenges, including challenges across breaking silos across patient organizations?
Thank you for that question. And I sort of represent the lived experience, and we have seen that over the past few years, there has been a slow but definite recognition of people with lived experience and the contribution that they can make to service delivery as well as access to right information. And in the context of universal health coverage, not only access to the universal health coverage, but also the recognition that health literacy is important before you actually go to a center that delivers care. So over the last 2 years, there has been, recognition of this in the sense that there have been regional consultations as well as national level consultations of people with lived experience. And we know now that there is going to be a framework that will be shared with member countries to be able to make them understand what kind of knowledge and experience can be contributed by patients, communities, and families, and how this can then further shape the delivery and the services provided under universal health coverage. We like to say nothing about us without us, but unfortunately, when the design and the production of any policies takes place, then the communities are left out. And so the key is in co-designing, co-production, and co-delivery. And it is only through this mechanism that you can understand where the challenges are and what happens when health systems do not meet the expectations of people. I think in terms of successes, one of the major successes that we overcame the pandemic. And the pandemic gave us two clear messages. One is that rich or poor, strong health systems or poor health systems, everything failed and crashed. And it was only communities, families, neighbors that helped each other. And what it also taught us was that no one is safe unless everyone is safe. In the same context and corollary, unless we are looking out for each other and the communities are managing their health and owning their health, it will be very, very difficult to really achieve the goals of universal health coverage. So I think it is important that we focus on patients and families and not only speak at these kind of forums, but also make them inclusive by calling them to policy discussions at the design table, not at the delivery stage. Thank you.
Thank you. Dr. Fernando, I would like to switch to you now. We heard a lot about social determinants of health and the answers to health lying outside the health sector. You've done a lot of work on community-based research, operational research. Could you speak to this and the role of researchers in advancing health promotion?
First, let me thank WHO for the invitation. And I think now we know what we are trying to achieve at universal health coverage. Almost all countries in the region have done a lot. But according to our former public health minister in Thailand, we have to do better. Now, when it comes to addressing the issues or problems, challenges that we face in universal health coverage, now, most of these challenges are dealing with social determinants of health. Now, if you look at Sri Lanka, we have done well in the public health. We have been giving free healthcare from 1920s, and we have been doing very well public health in the region. And you look at the life expectancy, maternal mortality rates, neonatal mortality rates, infant mortality rates, all rates are really good. But still, we have challenges, especially with the transformation of the disease spectrum in the country and also in the region as well. So if you look at how to deal with non-communicable diseases, most of the approaches in Sri Lanka initially started with focusing on treatment, screening, and more general kind of prevention approaches. So as academia, especially the university that I represent, Rajat University of Sri Lanka, we decided to go on with inventing new community-based health promotion approaches of dealing with risk factors of non-communicable diseases. And this has worked very well, even though we have done small-scale research projects all over the country, but it has really worked. And this is something that the government should realize and scale up throughout the country. Because empowering community is something that we have to rely on when it comes to achieving universal health coverage or any health in the region, because money is a crucial factor for all the countries in this region. So when it comes to this, now as academia, we have produced very interesting research based on community-based health promotion principles, which shows cost-effective models to test out. So we have tested out some important cost-effective models by strengthening mothers groups, fathers groups, and various community groups. And also we have supported communities to involve in research as well. So we have empowered communities to take part in research. So then they will learn some of the principles of this research, as well as what kind of results they can produce, and also what kind of monitoring that they can do at the community level to see whether they are achieving this universal health coverage. So as Dr. David said, it's very important to involve community all the levels. So as academia, we have introduced that. And we are doing it in the small scale throughout the country. And we need to continue this with the support of government in order to achieve the universal health coverage, addressing the challenges of social determinants of health.
Thank you, Dr. Manoj. I think you've made the point about how to tap into the power of community. Now, Dr. Ravia, can you speak to the power of tapping into social business? And very conscious that Aravind Eye Care has grown to 14 hospitals and over 100 primary eye care clinics. What lessons can be drawn from your growth towards advancing UHC more comprehensively through using social materials?
Sure, thank you.
Yeah, I think to start with, we need to recognize that healthcare is essentially delivered by two sectors, broadly the government and the non-government, which will include both for-profit and charitable, non-profit sector. Having said that, I think the government by design has to kind of have a denominator orientation of making sure the entire population country's healthcare is taken care of. But while it comes to the non-government or the private sector, it is often driven by individuals' strengths, their specialty, or other motivations, investment and others. So you find eye hospitals, orthopedic hospitals, OBGYN hospitals, and so on, or specialty hospitals, tertiary care or secondary care. So you really don't find any organization in the private sector which spans everything. So that's one recognition we need to recognize, because I think that's where it's going to be, and we need to recognize that distinction as we try to create synergy. Coming to your question, the eye sector that I represent has kind of emerged over decades as a standalone specialty, and today there are literally thousands of eye hospitals that exist. And in some countries, I know for sure in India, Nepal, maybe Bangladesh, that sector accounts for a significant portion of the eye care. Like in India, over 70% of the eye care is by the private, which includes non-government sector as well. And then another interesting thing in eye care, which can spill over to others, is that it is, even though it's a subspecialty, a surgical specialty, it has had a very strong community orientation for more than a century. And then not only that, it is one discipline wherein at one level they have transcended all levels of care, primary, secondary, and tertiary, very much interlinked, like Dr. Somsak was saying, one of the do's. And the other aspect is that it has also been providing all aspects of care, from prevention, promotion, rehabilitation, and of course, curative is a big part of it. So I think in terms of leveraging, we need to recognize this difference. And I think there is a tremendous willingness to be part of the universal health coverage. And then just in conclusion, we must also recognize that UHC is also growing the market of healthcare, which is of a lot of interest to the private sector. So synergy can be created, I think, through multiple ways.
Thank you, Dr. Rivia. I will follow up with you we have 7 years left in a shared agenda of sustainable development goals. So what is your commitment towards advancing this as you think of the future? What is the requirement of other actors from quickly, maybe 1 minute?
Sure. Yeah, within our own institution, our own sector, we are deeply committed. We work with multiple organizations to promote this notion of how universal health coverage actually makes a tremendous business sense. So they're not in conflict. It is not something purely altruistic. So that is one thing that we are pushing quite a lot. But in terms of what we expect from other actors is to see how this whole thing can become more enabling. There is a big shift to primary healthcare, but then you'll find that the policies are not designed for primary healthcare. A lot of the healthcare policies, certainly in India, I think came into existence at secondary, tertiary levels. So even for dispensing medicines, you have to break laws to dispense medicines at primary level. Now, if you follow the rule, you can't do it. So same way around the commercial taxation. So we need to recognize that healthcare is as important as, say, food, agriculture. So whatever concession we made for agriculture, I think we need to also extend to healthcare. Whether taxation, supply chain, that's one part of it. Other one is healthcare is not in isolation. It is the big challenge in healthcare is in the demand side, identifying people, creating access. where I think if the multi-sectoral approach, interministerial approach of education, of industries, and no, they all recognize that our children has got to be healthy, our workers have got to be healthy, and they make it mandatory for the healthcare. Otherwise, it is like breaking teeth, to get entry into those sectors. So those are all the areas I think it can make a huge difference if we take a more holistic perspective.
Thank you. I think Dr. Manoj links to that same question, reflection from you. And also we heard this challenge between policy and operation. So what is your recommendation as you're thinking of role of researchers and operational research to bridge this gap?
Yeah, now, if you look at the recent history in Sri Lanka and also in the region as well, most of the researchers took the burden of looking into the impact of various determinants like tobacco consumption, alcohol consumption, and other social determinants impact on health. This is a recent development, and many researchers have come up with very interesting findings. So I think the government should take the lead of incorporating this finding into the policy. But one of the challenges that we face in our country is that, when you try to develop policies, you have to deal with many sectors, not only the politicians. Especially when it comes to the private sector, the corporate sector, most of these corporate bodies are headed by the so-called CEOs of the tobacco alcohol trade. So they decide the policies, they control the policies. And when it comes to the politicians, this is a very common practice that you don't rely with evidence. What you need is a kind of a document that you should market for whatever the target group that you want. And this relying on evidence, because as academia, as experts, we produce evidence. And also there should be a drive for the young scientists, young researchers, young academia to go in this direction and produce the real effective evidence, not from the hard science, but also the implementation science as well. Because I can see a lot of people are now talking about this community-based involvement from Bangladesh, from India. You can see the involvement of the community. But what we see in most of these instances, we showcase in community, but we are not putting emphasis on highly incorporating these groups throughout the policy process. So this is something that we have to focus on. I am sure this challenge will be there in other countries as well. So we are trying our maximum best to deal with these challenges by exposing how these forces are acting at the policy level. We are happy that Health Ministry in Sri Lanka is doing well comparatively with compared to other sectors. And we have come up with some interesting policies. Our whole UHC is now focused on achieving a very good primary health care. The system has changed. A new shared care cluster system has been introduced. So still we are believing in these low-cost models, low-cost approach, while we are continuing this free healthcare. So this is a very important area that we should focus on, what I've been pointing out.
I think Dr. Manoj, you have transitioned nicely to Dr. Devi to see what can patients and civil society commit to, what do they expect from other actors, including the state.
In terms of recommendations, my immediate ask would be to recognize patients, communities, and families as a voice that gives credibility to the policy-making process. Right now, we are considered activists, and most governments don't recognize us. So that would be an immediate ask. The second one would be to break down the power silos, and instead of a top-down or a bottom-up approach, have an inclusive one. Also, healthcare is very fragmented. So how can we look at patient journeys and have a care continuum pathway that looks at the patient as a whole and not as a therapy area or a subspecialty? I think that is extremely important. More and more governments invest money in siloed programs, forgetting that there is a human being that is actually receiving those benefits through those programs. So I think that's extremely important. In terms of what we can give as patient groups, we can break down the misinformation, disinformation pandemic, and improve health literacy among communities so that people know when to go, where to go, and who to go to. and what to accept and what not to accept, and build the capacities of communities and patient groups so that they follow the advice of their care providers and do not switch between systems or stop and start their medications, and there is better clinical outcomes in the process.
Thank you, Dr. Devi. I apologize for the limited time we have together, but I will give the last words to Dr. Sala. Dr. Sala, Dr. Devi has put it very nicely that we don't want siloed approach. We want a comprehensive system that looks at the people. So can you speak to BRAC, your vision forward, how you're going to address the many challenges that are emerging in Bangladesh and in the region to drive this?
Thank you. I'll be very crisp and quick this time. One is that I think community network, as I mentioned, is very, very important, community healthcare workforce, but they cannot also just operate in the way they have been operating in the last 20 years because of the changing needs. So they needs to be upgraded. They needs to also look into the sort of the changing needs, like non-communicable disease, mental health. So these are some of these areas, but it also needs to be anchored of a national system. We are now working with the government to make it part of the community clinics that was set up by the government. The second bit is we need to, I think, look carefully in terms of the health insurance and also the data management as a whole, because a lot of data is being collected, but are we making the most out of the data that we are collecting to kind of support our decision making? I think that's very important. And the third bit would be in terms of public, private, and people partnership is becoming extremely important, more and more, because there are innovations happening that now needs to be delivered at low cost, at scale. Thank you.
And thank you, Dr. Sala. I think I really want to thank the participants again. And so much of what you say echoed what Professor Somsak was presenting. So thank you very much. I think appreciate your time for making the time. Thank you. Thank you, Dr. Sala.
Thank you, Mr. Ibadat Dhilan and all the panelists for this interactive session. Now, may I request Mr. Manoj Jhalani, Director, UHC Health Systems, to introduce the winner of UHC We Want and to present his closing remarks.
Excellencies, dignitaries, experts, partners, members, civil society, colleagues. I am indeed privileged to now announce the winners of UHC We Want region-wide art and creativity competition. As you're aware, we had three categories: drawing, painting competition, digital art and photography, and short video film making. And these were for 3 different age groups, up to 12 years, 13 to 18 years, and 19 to 25 years. And there are generally 3 prizes, each carrying first prize $300, second prize $200, and the third prize $100. So without further ado, let me now announce the winners of the UHC We Want. Can we have it on the screen, please? Wow. So this is for under 12 years, drawing and painting. And the first prize goes to Miss Takwa Malik Ritwa, and she's from Bangladesh. Okay. And there's another one, the 2 first prizes, in fact, Mr. Parab Rohit Dhoka. He is from India. And the second prize goes to another 2 candidates under 12 years, all very young kids, Ms. Tafdi Ahmad Purno and Ms. Swang Le Pyae. And the third prize goes to Ms. Sumedha Gupta. So congratulations to these young winners of first, second, and third prize. So 5 prizes in all under 12 years. Can we move to the next one? This is drawing and painting, 13 to 18 years. And the first prize goes to Miss Anika Saxena. The first prize also goes to Mr. Samia Malik Orpita. And the second prize, again 2 second prizes for 13 to 18 age group, Miss Shanvi and Miss Ekta. And third prize goes to Miss Shokhasri Sai Lakshmi. So these are 5 prizes again in the drawing and painting category, 13 to 18 years. Congratulations to all our young budding entrepreneurs. Yeah, this is the category 19 to 25 years, drawing and painting. And the 2 first prizes here also, Mr. Ishwar Thapalia and Mr. Prabesh Koirala. So 2 first prizes. And the second prize goes to Miss Yaram Shetty Jyotsna Rao. And the third prize goes to Miss Kanika Pandey. Congratulations to all the prize winners in the 1925 age category. Now, this is the digital art and photography under 12 years, and there's only 1 prize, and that's first prize goes to Yotsafat from Pinji, from Thailand. Congratulations, Yotsafat, on digital art and photography. In the digital art photography section again, 13 to 18 years, we have 2 prizes. Miss Sarthasuk Tamarangsi from Thailand, and second prize to Mr. Aditya Ranjan. Congratulations to these 2 prize winners. Then this is the digital art and photography, 19 to 25 years. The first prize goes to Mr. S. Khailon Waipe, and the second prize goes to Mr. Andrew Jonathan Brahms from Indonesia. Congratulations to these prize winners in digital art and photography section. In the short video clip under 12 years, we have first prize going to Miss Pema Choki Pelmo from Bhutan. Congratulations, Pema.
This year, it was accessibility to care, quality of care, and financial protection. My country, Bhutan, since 1970, has offered free universal health care to all its citizens. These health services are free and ensured in the constitution of the country. Basic package of essential services ensures access to traditional medicine, maternal, adult health services, diagnostic, security, and full emergency services. Services as well as specialized services for vulnerable groups such as older persons and persons with disabilities. All these healthcare systems and services are free of charge. I'm proud to say currently 90% of the population are accessible to the services with rural clinic. All this is brought about with introduction of public healthcare (PSC) scheme that forms an important part of the national social protection flow, ensuring universal accessibility to basic healthcare service. Thanks to the Ministry of Health of Bhutan and all donor agencies and individuals for such visionary moves. Thank you. Stay home, stay safe.
Oh. Congratulations to this bright young girl, very well deserving winner. Ms. Pema Choki. Thank you. Let's cover all. Okay. Now let me also provide those closing remarks. So today we have you've deliberated in depth on the importance of working together to advance universal health coverage. And throughout your discussions, you have highlighted the critical role that the primary health care must play in your efforts, with its focus on integrating essential health services and public health functions, promoting multi-sectoral and multi-stakeholder engagement, and fostering social participation, community empowerment, and engagement for health. In the region's onward journey to orient health systems toward quality, accessible, affordable, and comprehensive primary health care to achieve UHC, I assure you of WHO's full technical and operational support. I'd like to express my deep appreciation to Dr. Lote Sherring, the Honorable Prime Minister of Bhutan, for his presence today and for his whole of government, whole of society approach to making UHC a reality. I also extend my sincere thanks to excellencies from Timor-Leste, Thailand, Maldives, India, and Nepal, who continue to demonstrate their commitment to and support to this important cause. Lastly, I'd like to thank all dignitaries, panelists, experts, partners, and colleagues who have joined us today and shown their dedication to work together for universal health coverage. Let's now take this opportunity to get to know each other informally over lunch, and I conclude this summit. Thank you very much.
Thank you, everyone. For those who join online are here today, the lunch is served outside. Thank you.
Honorable Chair, distinguished delegates, we cordially thank the WHO Southeast Asia Regional Office for initiatives in conjunction with International Universal Health Coverage Day and for inviting the IFMSA to
UHC, Universal Health Coverage, where all individuals and communities receive their health services without suffering financial hardship. This year is